Hi, my name is David Liu, and I am a medical oncologist and a computational biologist. I'm an instructor here at MGH in the Cancer Center. And my particular interest is developing computational approaches using patient samples to dissect therapeutic response and resistance. So essentially taking patients who respond to therapy, who don't respond to therapy, doing molecular characterization of their tumors, and determining what are the determinants of therapeutic response or resistance. I was fortunate to be invited today to speak a little bit about a really interesting case study, a molecular tumor board of an exceptional responder to immuno-oncology. So this is a patient with metastatic melanoma who was treated with sequential immunotherapy, first nivolumab, followed by ipilimumab, which is first a PD-1 inhibitor, followed by a CTLA-4 inhibitor, followed by nivolumab for a maintenance therapy for a full course of about 2 years. And so to describe his course very briefly, this gentleman had initially a very mixed response to therapy with reversion in some lesions, predominantly like intrapulmonary, but also progression in many other lesions, including subcutaneous, lymph nodes in the inguinal area and retroperitoneal area, and many other areas. And in fact, looked like because of his progressive disease in multiple locations, was thought about the clinical team was interested in actually putting this patient on hospice when he didn't really respond very well to nivolumab, then on ipilimumab. But then actually before they actually got to that point, the patient had a remarkable change in condition where he turned the corner, things started improving, and in fact he had a complete clinical response to therapy where basically all his lesions disappeared, except for a couple of lesions where, as often seen, these are probably scar tissue with no residual viable tumor cells. And in fact, he went on to complete 2 years of complete immunotherapy, had no evidence of disease at the end, and then was subsequently followed by screening CT scans, and subsequently had 9 months after the end of therapy, developed a isolated metastatic lesion in the colon, which was resected with no further systemic therapy, and then 6 months later had a occipital lesion in the brain that was detected on screening CT, that then was resected again as a single oligomet with no evidence of a disease anywhere else. And a year after that point, he still continued to have no evidence of disease. And so what happened was, over the course of therapy for this particular patient, because he had a very delayed response to therapy, we had a pretreatment tumor. We had many tumors that were actually resected during the course of therapy because he had such progressive cutaneous disease that these lesions were taken from the skin for palliative purposes, as well as the recurrent lesions after the development of resistant disease. And we did a complete kind of molecular profiling of these tumors using whole exome sequencing to look at the mutational profile and to do phylogenetic analyses to kind of analyze the tumor evolution over the course of resistance response and later on the development of resistant disease again. What was really neat when we did this is we found the high points of our findings were that, one, there was quite a lot of heterogeneity even before beginning therapy. So we found 5 different lineages, at least, that occurred at the initiation of therapy that had very distinct genetic alterations associated with them. And in fact, we found 4 different genetic mechanisms that have been associated with disease progression as well as immune evasion. And the really interesting thing is that when we looked at the resistant tumors that came out, that he subsequently developed, that all of those resistant tumors, both in the bowel and the brain, came from a single lineage. And that single lineage was characterized by a deletion of a region of the chromosome 15q, which includes beta-2 microglobulin, which has been described and shown by a number of different groups that it is a beta-2 microglobulin is necessarily a protein for the presentation of antigens to the immune system. And so if you lose beta-2 microglobulin, the tumor cell no longer presents these neoantigens and to the immune system and becomes invisible essentially to cytotoxic T cells, and therefore evades the immune response. And so one of the things that, but in addition, we also found that these resistant lesions had acquired additional alterations from the pretreatment tumor lesions that then that further increase the resistance of these tumors to immunotherapy. So I think the case highlights a couple of different principles that were really interesting to us. I think one is that there's really substantial tumor heterogeneity that can exist in patients even before even before you have any kind of therapy. And in fact, those resistance mechanisms can be across all these different lineages. This, however, does not mean that the tumor is not going to respond to therapy. In our patient's case, he had a delayed response but had a really good and exceptional response. However, in the resistance case, I think the resistant lesions demonstrated the importance of antigen presentation and the importance of beta-2 microglobulin loss as a mechanism to evade the immune system, but that in itself was not sufficient. It actually required additional immune evasion events, including like P10 deletion, as well as a genome doubling and a CDKN2A biallelic deletion. And so this promotes this idea where there is a interplay between the immune system and the tumor, where there's almost an arms race, where the tumor is trying to evade the immune system and generates an alteration that evades the immune system, and the immune system attacks back and is able to clear the tumor, and the tumor again develops additional alterations, suggesting that the development of clinical resistance is actually much more complex than just having a single resistance alteration that you can find. And so, and overall, I think the major points that we want to bring is that clinical resistance, that the molecular characterization and the deep analysis of patient samples is a really important complement to kind of preclinical models and in vitro models to actually help us understand tumor evolution and the development of resistance within patients themselves. And so one of the things I just want to encourage everyone, like for the folks who have clinical practices, is that there's a lot that we can learn from our patients, and what kind of, and their clinical course. So if you have any really interesting cases and other things that you think that, hey, it'd be really cool to kind of dissect and figure out why this patient had the particular response that they did, I would encourage you reaching out to the academic institutions in your area and other places and look at those potential collaborations, because I think that's the way that we're going to understand how tumor responds, resists, and evades kind of the immunotherapies. So that's basically the highlights. I want to thank you for watching this talk, and thank you to the Chabner Colloquium and Dr. Chabner for the opportunity to speak here today. Thank you very much.